So tonight's format, for those of you who joined us the first time, we had one speaker. This time we have got an amazing panel led by moderator Tim Murphy, Vice President of Health from Alberta Innovates, who's going to lead this discussion. And we really look forward to this being an engaging opportunity and evening. We know that there are people working in this space. We know that there are people that care about this space, that have questions and see the possibility. So we want to hear your thoughts. So towards the end of the discussion, we're going to open the table up, and my colleague Vaughn's going to try and manage the unmute and mute, and we're going to engage as many people as we can in this conversation. And with that, I think I'm going to turn things over to Mr. Tim Murphy, who many of you know, to lead this discussion. And here we go.
Very good. Thank you, Christy. Thank you for that great introduction. It is truly an honor and privilege to be here this evening on this great panel. The Alberta Machine Intelligence Institute is one of the centers of excellence in the world of artificial intelligence and machine learning. Before we begin, I'd just like to acknowledge that even though we're conducting this webinar virtually, that we are on Treaty 6 territory, and the ancestral and traditional territory of the Cree, the Dene, the Blackfoot, the Saute, the Nakota Sioux, as well as the Métis. And we acknowledge the many First Nations and Métis and Inuit whose footsteps have marked these lands for generations. So recognition to that. So thank you for your time, for being here this evening. I know everyone has been impacted, and everyone's working very hard and has been impacted by the global pandemic since it was declared on March the 11th in different ways. And just based on what Christy said, I just want to give a shout out to all those on the front line of the COVID-19 response, those working in AHS, those working in long-term care facilities. Thank you for caring for our loved ones, and thank you for being there for what you do. We really appreciate all of your efforts in this regard. The second thing is, I just wanted to acknowledge that many of you are suffering from webinar fatigue, right? You have many choices with your time, and I know that people are Zooming from one meeting to the next, so really appreciate you taking time this evening to be here after hours at 5 o'clock to be with this organization and to help move forward with regard to this important topic that we're all going to work through together. So we have got really a rock star panel tonight to go for this topic of artificial intelligence in a learning health system. I'm going to make a few opening comments and have a few slides to go through just to frame the discussion about what is a learning health system, just to level set that for the audience and for the attendees. And then we've got, again, back to the rock star panel, we have Dr. Randy Goebel, who's the Amii Fellow at the University of Alberta, esteemed scientist and thought leader in artificial intelligence machine learning. We have Dr. Neesh Pannu, who's the scientific director of the Kidney Street Clinical Network at the University of Alberta, who really brings at the coalface, the clinician perspective. And then we have Dr. Lawrence Richer, who's the Vice Dean of Research at the Faculty of Medicine and Dentistry, University of Alberta, who really is a clinical integrator, right? So he's one of those knowledge synthesizers who works with the academic world and he works with the clinical research world, and he's also a clinician as well. So, I mean, I can't think of a better panel to actually begin to have this dialogue and discussion as we move forward. But let's move forward because a few comments to frame things. We know that artificial intelligence and machine learning holds great promise and potential. I think everyone has caught the hype cycle in terms of what this can do. Yet despite all this potential, the implementation of AI and machine learning in clinical practice has remained elusive. We have work to do. So the question for the panel tonight was just how can we in Alberta create an ecosystem where we create the winning conditions for that application of AI into healthcare, and how can we do that well, and how can we do that in the context of a learning health system? So next slide, Zovan, on this one. So this is a diagram that basically shows a learning health system, and I guess there's a lot in here. This is the Manier article on a learning health system. What I really want you to take away from this, if you think of the learning health system as an innovation stack, there's various components and layers to that stack that achieves the actual magic of what we're trying to achieve in a learning health system. At the top layer, you see where it says learning health system outcomes on the left, you see the performance layer, which is really the goals of a learning health system. And The main goal of a learning health system is one that rapidly and continuously transforms knowledge into improved patient outcomes at lower cost. Period. That is what a learning health system does. And it's framed oftentimes in the Institute of Health Institute in the US talks about a quadruple aim. So we want to get the best patient outcomes for the lowest possible costs with the best patient experience and the best provider experience. But that's the top layer of that innovation stack, which is the true north of what a learning health system is intending to achieve. If you go to the middle box on this slide, it really shows what I would call the scientific layer, right? Which is really how you get knowledge, how you generate knowledge from data, how knowledge then gets transformed to practice, and how performance of the system then feeds back to the data and creates a continuous loop. And that scientific layer really models the dimensions of science in that knowledge translation cycle. The third most important layer is the organizational layer. And that's a layer that really talks about the social dimensions, but it brings in the important elements of governance and ensuring that all the pieces of the puzzle fit together. And then we're going to get into this later on with the panel with Randy and Lawrence and Neesh about there's another layer in that innovation stack that's the data and the information technology layer, right? And that layer really provides the technical dimension of a learning health system. And what that enables things to do is it enables us to have a breadth and depth of data that can be applied to artificial intelligence and machine learning. And that's kind of in that cycle of the middle part. And the last layer, the fifth layer, and also not last but not least, it's also very important and critically important for a learning health system, is the bottom part, which is the connected and aligned ethical and security layer of the model in terms of the ethical dimensions, right? So, and I think what's really at issue is the interrelationships amongst this sort of innovation stack and how the component parts fit together and interrelate. And the principles at the bottom are very important. So those principles really guide the evolution of the learning health system as it moves forward. And I think, and the pieces of that innovation stack, if we think about it that way, are really the learning health system, and they've all got to fit together. So I often hear people say, whether they be a researcher or an institution or maybe even a company, saying, what we need is all the data. Just give me all the data, and we can apply artificial intelligence, machine learning to that data, create an algorithm, and we can begin to implement things. But you got to think about it in a bigger stack, because if you're missing one of the pieces of that pillar, it's really hard to advance and move forward. And I think the panel will get into that tonight about the different perspectives to this model. Next slide, Siobhan, please. This is something that Randy's actually been really much involved with, the Alberta Precision Health implementation plan. And this is a similar model. If you think about that innovation stack again, you've got the elements and components of that. But the difference of this model, what I really like about this particular model, is it puts the center and the patient engagement right at the center. And in Alberta, we have many great examples of strong patient and citizen engagement. We've had the Alberta Spore Support Unit working since 2015 with a strong patient engagement platform and philosophy. We have PACER that's been working in that context. So we have that middle center pretty well worked out. We also have the 7 critical pieces of the puzzle in those slivers, which again, get back to the scientific later. You see the data architecture in there, the importance of that, the importance of science to help drive the model and how that goes. And they're surrounded on the whites by the goals on the outside. And then you have the 4 interlocking objectives on the outside of how that works. But you can see how that learning health system is really predicated on deep knowledge of the individual and populations. And I know Randy's going to get into that in his sort of talk around why that's important. Why do we have to have deep granular data and knowledge to help drive that activity? How can we get data-informed discovery and innovation? How do we translate that knowledge for impact? Because that is, again, the essence of a learning health system for that buzzword. So that's next slide, please, Yvonne. This is a different look, and I just want to put this out because one of the things that as we implement new models of care and begin to look, and this one's particular right now with COVID-19 and the acceleration towards virtual care models and the digitization of a lot of activity, including, for example, this webinar we're having this evening. The digital health learning system is also part of this as well. These things are not different, they're the same, but this model really picks up some of the pieces of the interconnected data, whether it be for social data and health data. It picks up the pieces of governance in the workforce model, and it shows how the cycle, the flow of that data in real time allows one to project what we're trying to do and achieve. And this is something at Alberta Innovates in terms of our digital health strategy is really important to us. And I just want to make sure this is a complementary piece as we think about it going forward this evening, that this digital health provides another source or layer of data to give us that granularity, right? To give us that information. And we can harvest that in real time and then provide societal benefit in the interaction, how the people interact with the health system and how they interact with their lives. And it's the connection of those two things, I think, that really help a learning health system and artificial intelligence and machine learning move forward. You know, it's often said that a patient will visit their provider 3 times a year, right? So that creates 362 days of the year where we don't have information on the patient. We have gaps in our knowledge of what the patient's doing. So I think what we need to do is start to work towards bringing engaging patients into that discussion so we can help understand why that's important for their health and for their well-being. Next slide, Saban. Now this slide talks about, this is a slide that we use in Alberta Innovates to sort of discuss the shift in paradigm. And I was on, yesterday, I had the privilege of attending the Strategic Clinical Networks meeting. And Verna, you presented the goals and vision for Alberta Health Services, which is tremendous because she said shifting from acute care to community-based care, right? So that shift in activity. So just to orient you to this slide, on the x-axis is the cost of care. As you move to the right, the cost of care increases. And on the y-axis is quality of life. And as you go up that line, the quality of life increases, right? So what we're trying to get to, so Saban, if you just hit the button, just hit the button one more time, Saban. Thank you. So what we're trying to move is really from acute care to primary care towards healthier communities, right? And the 4 main drivers that are driving us, that are driving systems today, learning health systems in that direction, I think we all would agree that cost is a huge issue, right? In terms of the acute care. Most cost comes in the acute care system and how it's provided. That's a huge driver. The second driver is the consumer. So we have, you know, in every other aspect of our lives, it's more individualized, it's more personalized, and it's more connected, except for healthcare, where we still have a lot of physical environments we have to go to actually receive the care. That's important. Number 3, the third driver moving up that arrow to healthier communities is the technology. The technology now, digital technology now allows and permits people to work or to receive their care in different forms. With the COVID-19 outbreak, I heard from Ontario and in Alberta as well, there's been 80 to 90% of transactions have been happening virtually. I think that's come back in Ontario to 50% of the transactions. It used to be 10 to 20%. So there's been this rapid acceleration towards these virtual care models, which is terrific because that would enable that to happen. And the fourth driver of what's moving from acute care to healthier communities is the social determinants of health actually drive, and Randy's going to talk about this in his talk about the comprehensiveness of the data required, but those social determinants of health drive, 60, 70% of health outcome. And one of the goals of a learning health system is to improve health outcome. So again, we have to think more holistically about connected homes, integrated biosensors with the patients, how that information and data can be gathered, can be harnessed, can be served up so that we can begin to predict what might happen moving forward in the care trajectory of our patients. And I would submit to you that the healthier communities, to get to there, it's digitally enabled and it's data informed. And that is a learning health community that we need to create in Alberta as we move forward. So what I presented in those 4 slides are not mutually exclusive slides. They're all saying the same key messages that we have to do that. And again, I'll now turn over to the panel, and I'll turn it over to first Dr. Randy Goebel, the Amii Fellow at University of Alberta, to go through his talk and introduce yourself, Randy, to those assembled this evening. And then we'll go to Neesh and then to Lawrence next. So Randy, over to you.
Hey, thanks a lot, Tim, and thanks for the introduction. Before I say a little bit about what Tim highlighted about the passion for data, I'll give you a perspective on my role in this kind of activity. I am a computer scientist, a data scientist studying AI and machine learning, and I probably represent the most impatient person on the panel with respect to what can be done. And the impatience is with how we marshal and join the puzzle pieces that Tim spoke of so we can actually make a difference. You can think of this from all of the spectrum of the people that joined in from very many different perspectives, but in addition to everyone's professional background that they put in here, from AHS, from I think is SHS, Saskatchewan Health System. Anyway, from the people there, the important thing is to make a difference in how you decide to take clinical interventions when somebody needs them. And that is closing the loop on the health learning system, is to say we take outcomes and we identify and improve the capture of data on outcomes to be able to find patterns to feed them back into the health system so that the care you receive next week or next month is informed by what happened from today. And so that maybe is the bottom line. Now, Tim prompted us earlier to talk about a variety of things, including Eric Topol's book about I think it was called Deep Health, right, Tim?
Deep medicine.
Deep medicine. And one of the things that was spoken there, I factored out the word deep because it was about phenotyping. What it really means is the identification of cohorts where you are able to choose the best intervention possible at any one time. This slide is the paying homage to the Human Genome Project and Francis Collins, who sold the idea of raising money to be able to say we can do the genomic assessment of everyone. And once we get down to you being different from everyone else, then we can target interventions directly related to your genome. That's actually, in some sense, impossible because we can't deliver healthcare to every individual. We need to identify those cohorts which can best take advantage of interventions that are the best practice currently. To give you an idea, the strategy that orthopedics person takes in the emergency room when you come in with a broken leg is largely independent of your genome. And so in the next slide, what you see is the use of and the intended use of the health learning system. So if you go to the next slide, please, or maybe I can do that. Yeah, there we go. The intent is to use data to take everyone and separate them into cohorts that align with the current best practice in medicine. And this diagram just shows that one individual is in a cohort that has a genomic disposition that includes 2 genes, and that if he doesn't, then he's in that cohort, and if he has those genes, he's in that cohort. If he doesn't, he's in another one. The important part is that the determination of these cohorts is driven by the extraction of data from the health learning system. We're perpetually updating it. We're perpetually refining the notion of cohort or phenotype in this case, when we're identifying people with data who would best respond to the interventions we have. This goes all the way back to something very simple. So for example, my colleague Michael Mengel as a pathologist is always complaining about how we retire diagnostic tests from the list that Alberta Health Services does and pays for by getting rid of those things that cost too much money and provide no data insight, and repopulating them with the science of the learning health system to say, here is a new test that has proved to be very good with respect to predicting, and therefore we should change the list of things that are done. So from the computer scientist point of view, the idea is to encourage my medical colleagues, both the clinicians and Alberta health stewards, and in fact, people around the world, to say, how can we refine the health learning system to be able to reduce cost by better identifying best practices hour by hour, day by day, week by week. Just to give you an example of some of the pressure that's arisen from the pandemic is, as I predicted with my epidemiological colleagues, that you will be gathering data to do contact tracing at a rate that's too fast for you to actually interpret. So a goal would be to identify at-risk populations by changes in COVID positive tests day by day or even hour by hour. But we actually generate too much data when we do COVID testing to be able to keep up with that refinement. So there is now work going on inside of AHS related to use of natural language processing, extracting signal from natural language records of the COVID tracing inside of the system to be able to accelerate the time to deliver a message about public health interventions, for example. So maybe that's a good place to stop, Tim, and move on.
Super, thank you, Randy. Now turn it over to Dr. Neesh Pannu, Scientific Director of the Kidney Strategic Clinical Network. And I neglected to say at the beginning that we do have, I mean, the strategic clinical networks, and Neesh is going to talk about that, are really micro-learning health systems in their own right? So we have good examples in Alberta of that. But I'll turn it over to Neesh, over to you, Neesh, to go through your slides. Thank you.
Thanks, Tim. Yeah, we'll just start with the first slide there. So I come here with a perspective of a clinician. I'm a nephrologist at the University of Alberta and a clinician scientist. So I have a background in epidemiology and biostatistics, and also as one of many scientific directors of the strategic clinical networks across the province. And I'm really happy to see we have pretty good representation from the SENs at tonight's meeting. So I would certainly encourage all of you to provide additional input into whatever comments that I make with respect to the role of the SCNs in this particular conversation. But I thought I would just, for people that don't know a lot about what the SCNs are and how they fit into the AHS Alberta Health Services mission, I thought I would just spend a couple of minutes to talk about that and then maybe discuss some of the key enablers in the province of Alberta, which would drive innovation in this area, and maybe some of the existing barriers as well. And then we can open it up a little bit further after we give our comments. So with respect to the mission of Alberta Health Services, certainly the mission is very consistent with this idea of a learning health system. And in fact, that is what we all aspire to. There were kind of four main principles that were identified in the HS mission. And really it's to provide patient-focused care, high-value patient-focused care that is accessible and sustainable. So we'll go to the next slide, please. The strategic clinical networks fit into this whole vision by specifically bringing together research, innovation, and clinical care. And really, so the first strategic clinical network was originated in around 2012. And now the number has changed a little bit over the last 5 or 6 years, but there are around 9 to 12 strategic clinical networks that operate. And really, these networks are collections of frontline healthcare providers, clinicians, policymakers, researchers, and people within the operational leadership within Alberta Health Services who come together to solve problems, essentially. I'll move to the next slide. So this is kind of a schematic of what that landscape looks like now. And as you can see, the mandate of these SCNs is really to improve health outcomes and in a manner that provides value for money. And as you can see, there are a lot of different stakeholders that participate in this process, everyone from patients and families to physicians and nurses, allied health, some involvement from government as well as a role for academic institutions here who have been very supportive of the work that has been provided by the strategic clinical networks. As you can see, the way that they're currently organized, they are quite disease specific in the sense that we have a cardiovascular strategic clinical network. I formerly belonged to the kidney health one, which now falls under the medicine strategic clinical network. And so, while we've certainly been able to unify our mandate through the development of these SCNs, you can see that the care in some respects still remains perhaps a little bit siloed. And the opportunity that I see with respect to artificial intelligence and the use of these types of technologies is to perhaps allow some amalgamation of all the data that's generated from all these SCNs and to use them to perhaps provide a more holistic approach to care for our patients who often may fall into one or more of these care areas. So I'll go on to the next slide. So in terms of strategic clinical networks, really, I mean, one of our primary functions is to identify gaps in care in the areas that we work in. And again, this is an area that we were having a discussion about this in the last couple of days with the rest of the panel about how artificial intelligence could be used to identify gaps in care. So could we identify high-risk cohorts using population-based data? And by doing so, anticipate care needs for those people and perhaps intervene before disease progresses to a state that requires more acute and often more expensive care. So evaluation of innovative solutions also does require data collection, data management, and data analysis. And so what is the role of artificial intelligence in terms of organizing that data? We'll go on to the last slide. Oh, okay, I guess that's it. So I would say that, from a strategic clinical network perspective, one can imagine many different opportunities that AI could provide, whether it's developing predictive analytics for specific disease processes, whether it's and prognostication, whether it's matching patients to clinical trials. And I think Lawrence will talk a little bit about this with respect to the applications in research, whether it's identifying high-risk cohorts, as I pointed out, or perhaps optimizing workflows amongst the various operational areas in Alberta Health Services. So there are, I think, multiple different areas where we could leverage the power of artificial intelligence. I think we are lucky enough to live in one of the most integrated healthcare systems in the world with population level data. And we have a number of facilitators to the use of artificial intelligence, including our relatively newly deployed electronic health record, which is a massively powerful tool to collect the data and generate the data that Randy was talking about earlier. So, that said, despite being quite integrated, there are certainly areas where we could perhaps increase integration, since many of the electronic health record, much of that data comes from acute care, with the understanding that much of the healthcare delivery doesn't necessarily happen in hospitals. So there are certainly, barriers that we can discuss later on in this session, but I certainly think that the SCNs are a key enabler of this type of work. I'll hand it over to Lawrence, and we can discuss some of these topics in more detail.
Excuse me. Thanks, Neesh and Randy, and thanks for the opportunity to participate in this panel. And thank you, Tim, for that great introduction to set the stage. I'll tell you just briefly a little bit about myself. I may ask for a change in my job description based on Tim's advice as a clinical integrator, because that is how I feel. But I officially am the Vice Dean Research in the Faculty of Medicine and Dentistry. And for clinical activities, we're really trying to integrate research within clinical care is a challenge that there's no one solution to, but it certainly has been my passion for the last several years. The other passion I've had over my career and training has been informatics generally, computers early on. I used to play with databases. I recall in residency training, my senior fellow suggesting that if I spent as much time studying neurology, I'm a pediatric neurologist, as I did other things, I might be a better pediatric neurologist. But it has actually resulted in a very interesting and fun career that I've had so far, being able to blend my passion in clinical medicine, my passion for informatics, and my passion for research. The other activity I have begun leading since this summer is as academic lead of the Precision Health Initiative the Precision Health Signature Area at the University of Alberta. And precision health is a term that means different things to different people, but it I think definitely encompasses to a degree what we're talking about here today about a learning health system. The tools that will be applied in precision health are going to be very similar to the tools that are necessary, and the structural changes that need to occur for a learning health system to be a reality. So the way I would frame my introductory comments would be to say, we've heard from Randy and we heard from Russ Greiner at our previous presentation. We have some of the world experts right here in this province in artificial intelligence, in computational sciences, people who know how to work and move data. We have in Neesh's presentation a wonderfully integrated health system. The strategic clinical networks are really a goldmine opportunity to leverage. The question I have is, are we doing it? Are we a learning health system today? And I think the answer, a fair answer would be maybe in pockets, but where we really want to go is probably not where we are today. And that's where my interest lies, is in trying to understand what are the ingredients, what is necessary for meaningful applications of artificial intelligence, machine learning to occur in the health system. And I certainly don't have all the answers, and I'd really like to explore that more with the panel members and with Tim as well as the audience on that. But I did give a little thought to some of the things that I've observed are necessary. First and foremost is not to make any assumptions about what you think the problem is. The problem we're trying to solve is not the deployment of AI or that someday we'll realize we are a learning health system. The problem we're trying to solve is really the everyday problems of patients, of our health system, of the cost of our health system. And each of those problems has its own unique needs. The construction of what the problem is truly requires a village. It requires a team, a multidisciplinary team to really understand it, and it has to include patients. Really, if we are going to use data in different ways, in unique ways, and in more powerful ways, we do need patients to understand that this is happening and why it's happening. So number one would be, make sure you understand the problem and you vetted the problem as best you can with those who are at the coalface of those problems, including patients. Number two is make no assumptions about the data, whether you can access it, whether it's the right data. And that's a common failure of proposals, is that the assumptions about the data availability or the quality of the data or the data that you thought was there were false to begin with. And lastly, that you really need to understand the environment that your solution would be used in. And yes, we are wanting to move from an acute care focused health system to a more community-based focused health system. Those environments are very different in the challenges that you have in any proposed solution. So really understanding if it is an application in the acute care setting, you really truly need to understand the infrastructure, the information systems, the decision-making and governing bodies that are required to embed solutions into the health system. So those are the three main qualities of successful projects that I've observed. The last thing I'd say is I often hear people say, we're behind, right? We've missed the boat. And I've had the pleasure of hearing from other institutions, Duke University and Health System, Mayo Clinic, Kaiser Permanente. And the honest truth is there is no jurisdiction that's finding this easy. In my opinion, we have a tremendous opportunity here in Alberta to leverage assets and data, leverage an integrated health system work with our experts in this province, integrate academia with the health system as best we can, so that we can leverage all these talents to come up with the solutions that make sense in Alberta. Because if they make sense in Alberta, they're likely going to be marketable elsewhere, which then leads to Tim being happy and Alberta Innovates being happy that we are making progress in the knowledge economy. So I'll stop there.
Okay, very good. Thank you, Lawrence. Great panel, as you can see, everyone. So I have a few questions. Just wanted to prime the pump and get things going. And I guess in terms of we have about 150 people on the line. So feel free to, after we go through these first set of questions, to come off mute and actually join the conversation and dialogue. And the only thing I ask as a moderator that you direct your question to an individual on the panel, and you actually ask a question first. That's one of my rules. And then you can make if you have some clarifying comments after that question, you can make one or two clarifying comments after the question, but ask your question first, direct it to the individual, or if it's just to the general panel, let everyone know that. In terms of the questions, the themes I had was around, just back to Lawrence's point about capacity development, right? There's I see a lot of the 150 people on the line in the educational young careers. So question for the panel open, what are the competencies for artificial intelligence and health? And do we feel we're preparing the next generation for those roles and for those competencies right now? And if not, what do we have to do to actually get there? Like, what would that be? And a subsequent question would be to Lawrence's last point about the jobs of the future. Like, what are the career pathways and how are we preparing that army to be able to take advantage of this tremendous potential we have that Lawrence referred to? So, but just the competencies and training, anyone from the panel open to Randy, Neesh, or Lawrence about, are we training the right competencies? If not, what do we have to do to make that happen?
Let me say that the hype around artificial intelligence and machine learning far exceeds our ability to identify what you would call basic education. Amii, the not-for-profit, does a very good job in their machine learning certification, for example. And so we're only starting to catch up in the field that's relevant to the learning health system. Undergraduates in the Faculty of Medicine have connected with some of the graduates and undergraduates in computing science and have produced what you might say is a sort of a groundswell of enthusiasm for saying, we need to be educated for that future that Tim spoke about. So the good news is that the components and enthusiasm and engagement is there, but the academic role in education is to mitigate the hype role. I wouldn't want someone to take an online Coursera course in deep learning applied to health data and think that they are an expert if next year it turns out deep learning isn't the solution, for example. So there's a caution on the academic side about doing it incrementally and appropriately, but driven by what Lawrence said, driven by the goals, not by the technology. So maybe Christy can comment.
Christy, do you want to comment, or?
I'm going to let you guys run with this one.
Okay, so Neesh and Lawrence, from your perspective then, and we've talked about Randy's brought in the academic component, what about the health system component? What about preparing people for the receptor capacity? Or even at some point, the pull of the knowledge across the chasm between knowledge creation and knowledge use. So Neesh or Lawrence, do you want to comment on that?
Yeah, I could take a stab at that. You know, the needs are going to be diverse. The expertise in the computational data sciences, the clinical understanding, and then the interpreters in the middle. So they're not, a single person can't necessarily be all those things, but what each of those individuals will be is working in teams. Communication, in my view, is going to be the biggest skill. How can you communicate your potential solution to the provider or the clinician or the expert, the decision maker, in ways that they can understand then and say, I can see where that solution could be a solution to my problem. Mm-hmm. And then in the education of care providers, we do need to start to get them thinking about where solutions might be an option. And to understand enough about those solutions. I mean, it's not enough to spell AI. We have to understand what it means a little bit, and understand where it makes sense and where it doesn't make sense. To Randy's point, there's a lot of hype, but there are areas where it makes sense and that is a viable solution. And then there's going to be those integrators, those interpreters in the middle that speak both languages a little bit and are neither expert clinicians nor expert informaticians, but can translate. So communication really is a key skill. And then every possibility you have to integrate with other disciplines, understand problems from other people's perspective, and go through the effort of trying to communicate. That is really going to be the most important skill set.
Okay, thank you, Lawrence. Neesh, anything to add?
Yeah, I would have said exactly the same thing as Lawrence. I think you need people on the health side who can speak data science, and then you need people on the data science side that can speak health. And I think that certainly, I think the opportunities. I'm not sure that as a clinician that I am entirely aware of all the potential applications of AI, whether it's to a health system or even to an individual patient. So I think the idea of teamwork is going to be a necessary concept to this being successful and moving forward. I don't think that there will be a specific training path. I think it will be expertise in both areas, and then those, as Lawrence said, in between people that will have to move forward and provide their perspectives and kind of trying to think out of the box in terms of solving some of our health system and our patient problems.
Very good. Thank you, Neesh. I'm just watching the Zoom chat, the group chat, and I'm seeing a lot of comments about privacy security. As you know, that's in the innovation stack for a learning health system. That is one of the key layers. And I'll just add that I was presented with a Gartner survey recently that talked about, it surveyed about, I think, 700 private companies around the world. And they asked them, what are the barriers to implementing artificial intelligence in your business? And numero uno was security and privacy. That was the #1 issue. And I don't think there were even healthcare companies in the survey. So that's a very important topic to get right. So maybe I'll shift to Randy for a second, just about the importance of Randy made a really good point about the vast quantities of data, and those models are far superior than, having vast quantities of data are really more important than having precise data, even in terms of the artificial intelligence. And I've heard this, Randy, from scientists saying, and Lawrence has as well, in some of the projects we've done early on in Alberta, just give us all the data. Don't give us what you think correlates with what. Just give us everything. And again, how do you reconcile that with the privacy and security concerns that are real for both private companies and public companies in the ecosystem? I don't know if that's Randy, do you have a comment about that?
Yeah, it's an important question, because as hard as me and my lab have had to work to get access to data, the support that we get from a variety of people in AHS is also sincere, but has their own impediments to do this. So the solution is not to overthink which data provides potential solution to which problem, like Lawrence pointed out, is give me all of the data in whatever way you feel is secure and ethically stewarded, because remember that the deployment of AI and machine learning is not about just giving humans, clinicians, intervention tools. It's about finding pattern and signal in all data that humans can't find. We're not smart enough, we're not fast enough. And so to pre-constrain the problem we're solving by saying, okay, which of the gazillion data items we have do you need? The answer is all of them. So for example, in our proposals to find at-risk populations, we want access to all data, and we want to augment it with other data as well, right? Geopositioning data, such as we've talked to TELUS about, is an important aspect that AHS data has nothing to do with, but it's influential in determining moment by moment, if you get down to that granularity, spread of COVID. Similarly, in social media, we have no no impediments to using some of the social media, which are always already open and free range data. It informs, and there have been lots of sort of demonstration projects that show how that data is relevant. What we see uniformly across the planet is that the discussion isn't about which data solves which problem. It's about saying, how much data can we manage to be able to find insight into the problems? So that's a very good point, Tim. Thanks.
Very good. Actually, I'm going to shift gears here because I'm just, again, watching the Zoom group chat, and I'm gonna call on Mark Leduc. Actually, Mark, can you come off mute, please? You've got a great point here about the role of validating the trained algorithms in health systems and the role that U of A sees for itself. And what you're getting at in that 3-paragraph question, Mark, I think there's a question in there, is the roles and responsibilities between the academia and the health system, and how those two things can come together, because that handshake is absolutely critical for artificial intelligence and machine learning. So Mark, please come off mute and ask your question.
Yeah, so can you hear me, Tim?
I can, thank you.
Great. So it really has, I was speaking to two emerging needs. One is around the discovery side and how I'll use AHS as the example, but we know we have colleagues from other health authorities across the country on this call. But to apply these methods for discovery and learning around our own particular patient populations that we serve, and I'll add the business side, right? So one of the quicker wins might be to look at business needs. So things I think Randy was alluding to, but on the procurement side, how do we use business intelligence on HR and other applications that don't involve identifiable health information at all? So that will address some of the barriers that we face, and the methods I think can help are just as suitable in terms of training potential decision support tools around that. But obviously the bigger size of the prize that we have is around clinical utility and the potential to then take these ideas and sell them or make them available to other health jurisdictions. And we see this particularly in the context of diagnostic imaging, seems to be the tip of the spear of how these methods are promising. So there's the issue then around discovery, and then going beyond that. So I think AHS can work closely with our university partners around this now. There are challenges because of the scale of the records that are needed. And as Randy was alluding to, the breadth of other data that could be relevant to finding meaningful patterns. Nonetheless, I think there are methods to do that. The issue that I guess I have is how do we then go beyond, what's the role of the university and the health system partner, because it's not always AHS, but it could be others, to translate that into decision support tools that can actually make a difference for both either patients, if it's a patient-oriented opportunity, or to the providers, the clinicians actually providing care. The second piece that's emerging is really around vendors and other parts of the ecosystem, I guess, developing solutions trained elsewhere on other patient populations and other jurisdictions, including around the world, and then figuring out, well, to what degree are these algorithms validated, or any biases that are inherent in their data, how does that play out in our context, right? So it's a totally different business need and or skill set, and it can be done even with the internally generated solutions, but it certainly, I don't know how I would go about validating. Some vendor who's trained something says their product or their algorithm has been trained, it's AI enabled. And so now what do we do with that, right? And again, the university doesn't own the problem of solving this, but how can our colleagues help us crack that nut and figure out how do we have confidence in validating those?
Okay, thank you, Mark. I would just summarize in terms of the decision support tools. What is the role of the university, and not just U of A, but U of C as well, and in the post-secondary institutions? What is the role of that? And your second part of your question, just to summarize, where can Alberta win? Where can we win, and how do we get to win, and how do we do that moving forward? So to maybe for the U of A perspective, our panel are all from U of A, but they may not feel they can speak on behalf of U of A. Others can come off the line. I haven't seen everyone in the participant list, but anything Randy, Lawrence, or Neesh you want to add to the first question Mark asked?
One of the first very important components of what Mark said relates to what Lawrence said about identifying the problems and the reality that we should make knowledge translation a team sport, not an individual sport. Because, for example, most of us that have been involved with these kinds of discussions already know that a team that crosses the discipline boundary from the computer scientist to the health scientist in the university to the health scientist in the system, and things such as Deborah James have worked a significant part of the last decade to orchestrate, means we need these teams in place. And it's hard work to do that. It's hard work to create that and sustain it to be able to do that. The vision of the health learning system maybe helps encourage us to do that, to say, look what we are able to accomplish if we build those teams to address what Mark said.
Thank you, Randy. Neesh or Lawrence?
I was just going to say that I think the role of the universities here, you know, as has been said before, might be in knowledge synthesis and knowledge translation, as you said. So there are a lot of tools out there that have been produced by universities across the world. Even that information is overwhelming. So, you know, how do we choose the ones that are the right fit for our environment? I think there needs to be an evaluation strategy, and that may require the development of a task force. It could be a pan-university initiative, for example, and that would be working in partnership with Alberta Health Services, but I could certainly see a role for the university there.
Thank you, Neesh. Lawrence?
Yeah, I'll take a stab at this. Mark and I discuss this type of stuff all the time, but you know, these are interventions. These are interventions that may have a positive impact on health and may have a negative impact on health. And particularly when we think about algorithms derived from other data sets that may be biased or not applicable to our population, we really have to keep that in mind. So in my mind, a role here, I lead a clinical trial center, and I think in clinical trials, but the evidence needed for the introduction of these kinds of tools into the health system should be not much different than the evidence needed for a drug to enter the system. And we're going to have to think differently about how we do those kinds of studies, because it's a lot, when you think about it now, the randomized trial of a drug looks a lot easier than the randomized trial of an algorithm or some sort of prediction, because the necessary steps to have that thing embedded in your EMR, you know, properly implemented at the point of care so it doesn't impact workflow. I mean, the logistical steps to do that study are far more complicated. I do say our health regulators are waking up to this. You know, the FDA is starting to write guidance on the kinds of evidence that it will want to see for these devices to be viewed as acceptable. And I think we need to contribute to that commentary, and we need to try to provide that evidence that clinicians and decision makers are going to want to see before they decide whether to deploy something.
Super, thank you, Lawrence. And Mark, you want to comment from the Alberta Health Service side, from the provider side, in terms of the role?
You know, it's just, you know, it's the promise is exciting. The ability, the capabilities needed, we're still trying to figure this or learn that. We need data engineers, data scientists, and others, and we don't have those roles necessarily embedded everywhere. And so that's where our partners in universities are going to play a key role. We also have partners in the private sector that will play a key role, particularly around bringing things to market that AHS can buy. And I think that plays into their wheelhouse. There's people in the chat that are speaking to different components of that, whether it's IP or other components, investor dollars, et cetera. But so it's a complicated journey. I'm thrilled that Alberta is at the forefront of it, and I'm hopeful that you know, we continue to not just wrestle with these, but I guess really try to advance. And that's where the work that Alberta Health and others have been doing around the data haven model, where the computational environments are set up for third parties to come in and access data, or the synthetic data. You know, if that can work, then we can at least train things there and then validate it against real data down the road. So like, I'm excited about the opportunities, both particularly at the U of A with what U of A has been able to invest and build. We just now need to keep working on you know, that last mile piece. How do we get beyond just the discovery side and into its application?
Super, thank you. Just one more theme, and then I'll turn it over to the panel. I see again, there's the chat box is just lighting up, which is great. So lots of people, and feel free to come off mute again and make your point and ask your question of the panel. The last part I was talking about is and it started directed at Neesh and Lawrence, and it's around provider physician burnout, quite frankly, or provider burnout in the system. And it's the issue of predictive risk fatigue. We have webinar fatigue. We talked about that at the beginning of this webinar, right? Everyone's zooming from meeting to meeting and getting tired of that. But predictive risk. So I'm reminded of Dale Sanders, who told me a story once that he used to work for the U.S. military, and he'd do all this, take all this data and crunch all these scenarios for wargaming with the generals, right, in the Pentagon, and he'd present that to the generals, and they'd all go, "That's interesting. All these bad things can happen. That's interesting." Then he stopped getting invited to the meetings. They stopped inviting him, and he ran into one of the generals at a coffee shop, and he asked him, "Well, why am I not invited to these meetings anymore?" And the general said, "Because you just tell me all the things that can go wrong. You give us no ideas as decision makers of what we can do differently." So, prediction of risk without a plan or ability to intervene is a liability to the decision maker, not an asset, right? So I'm just wondering, from Neesh's point of view and Lawrence's point of view as clinicians, and this is going to come from both the system and maybe the academic system to the health system, but it's also going to come from patients in the not too distant future. We can see patients interacting with their cloud, getting the algorithms of information they upload into the cloud, their own personal clouds, and they're going to be armed with those algorithms going into their doctor's office and talking about all the different things that can happen to them. So from the provider perspective and the system perspective, Neesh and Lawrence, any thoughts about that? Is that a concern, or is that sort of, that's down the road, we'll worry about that when it happens?
Go ahead, Neesh.
Yeah, I mean, I think it is a real risk. Absolutely. I mean, even things like clinical decision support and existing electronic health records, I mean, there is a certain fatigue factor to them. And as a clinician, you often find that you ignore them. I mean, and I'm sure Lawrence would speak to that as well. I mean, it's a pretty common phenomenon. And I think your point is well made, which is that, I think before we deploy that type of technology or those types of technology in our health system or in our electronic health records, we have to think about, as you said, is there a solution? Is there something that we can do with this information? Because prediction is not enough. So in the absence of a specific treatment or a learning from that prediction, in other words, can we go upstream and learn how to avoid doing things to reduce that risk? That information itself is not necessarily overly valuable. So, I think those are, I know, certainly decisions that are currently being made within AHS with respect to even the deployment of ConnectCare, our electronic health record, because people are fatigued. And there are numerous studies that have shown that there is a certain, the impact of these things does wear off over time. And as you said, with information overload and wearables and patients bringing in their own data, that is only bound to get worse.
Yeah, I'll jump in. I mean, predict, right? I mean, that's what these tools can do. But if all we do is bolt together 1,000 predictions, absolutely, you're going to just tune out. I mean, the average, computational capacity is increasing exponentially. Our brains are not, certainly not mine anyway. The ability of clinicians to absorb information is not changing. And so the solutions really need to take that into context. Again, they just speak to the magnitude of the problem. We can predict 1,000 things, 100,000 things. But there's a decision maker, a human being there that's trying to navigate all these predictions. So the real tools that, that are needed, but I have not seen yet, are the ones that really synthesize and bring together the right information at the right time for the right patient. And that takes integration at a level that can't be done on a project basis. It can't be done on a per problem basis. It has to be done holistically. And again, that kind of brings us back to the topic. This is AI in health has a myriad of applications, but it needs to be embedded in a learning health system, an integrated and learning health system.
Yeah, the
Super.
framework.
Thank you, Lawrence. Go ahead, Randy.
It's just that I tell my colleagues when they ask me for help in clinical data, that I can generate 1 million different predictions from your data. You will have to invest the energy to be the subject matter expert that qualifies those. And in the context of the health learning system, it provides the framework for assessing exactly what Lawrence and Neesh said. It's that intervention time and the capture of data that feeds back into the system to improve it, not the computer scientist AI person. That's not our role.
Mm-hmm. So it's a shout out and a call out to the entrepreneurs on the line and innovators who have the right information, the right time, in the right place to begin to pull that together. So there might be there's a business opportunity there, because that's going to be the future of artificial intelligence and health. I want to shift gears to the patient and citizen, because actually in your diagram with the Alberta's precision health strategy, Randy, you put the patient at the center, right at the center of that entire precision health model, right. At the U of A and at the University of Calgary. The question is for Neesh and Lawrence around what would be the first thing you would say to patients and citizens to give them comfort about the advances in artificial intelligence in health? Like what would give, because I see a lot of comments in the chat box, we have to build that ring of trust around the patient, around their data, right? The data we're using. And as Lawrence knows from the secondary use data project, I mean, trust was the #1 word that came up early, often, in the middle, and at the end. And building that trust is really important. If that trust is breached, really, it's hard to get it back, right? You don't have to look to the UK and other examples where they didn't maintain that ring of trust, and they put themselves back a decade, cost them a lot of money in that process. But what would be the first thing you'd say to patients and citizens, and even Randy, to give them comfort as we move forward in this space?
Awkward. I guess I'll jump in.
Yeah, Lawrence, Neesh, and then Randy. How's that? Okay.
Yeah, I mean, you know, I think I would say to a patient, you know, probably coming, I'm a pediatric neurologist, so it's a teenager typically, and they've brought their cell phone with them, and that cell phone has become an integral part of their life, and it facilitates a lot of the things they want to do: communications, storing information, you know, whatever it is that they do with it's a tool that they use. And what we, as in the healthcare space, is we need those tools to help us consume all the information that's being thrown at us in ways that make it useful to make decisions for that, or help make decisions with that individual. And so it really is a tool to enhance and improve the quality of care that they receive. But all too often, I see that, because it brings it back to privacy. All too often it's seen as an all or none answer, a yes or no answer. You're all in or you're all out. It's all the data or none. And I think that's something we're going to have to get past, because when I log into, I don't log into Facebook anymore, but when I log into other social media type things, I'm given at least some choices about my privacy settings. And I think the health system is going to have to get to a place where we do allow some choice. Just because 90% of the population thinks it's okay, it's going to be the 10% that don't think it's okay that's going to block it. And so we've got to get away from thinking it's an all or none answer. We have to give that decision-making back to patients. And we have to use technology to do that. And it's not complicated in my mind, technology to do that, but we have to give that choice back. So it can't be an all or none answer. If you don't want to participate in this, then you should be given the choice not to.
Thanks, Lawrence. Neesh?
Yeah, I mean, I would just sort of add on to what Lawrence said. I mean, I think the onus is on us as healthcare providers to ensure that we can secure their data privately. And I think we need to be able to confidently present that to the patients. I think that, from a patient perspective, I think, the idea that you could provide, the concept of personalized medicine, that you could provide the right drug to the right patient at the right time. And this idea of phenotyping is very attractive. And I think that is the promise of AI. So, if we can maintain privacy, health data privacy, while being able to give them the advantage of giving them the right medication, matching them to the right treatment, ensuring optimal outcomes for that person, I think that is the discussion that we need to have. I think the other way to engage in this conversation with our patients is also to say, you know, these things can be used as tools to facilitate their own engagement in their own health. So often the healthcare that we provide is sort of a unilateral, it's often a one-way, unidirectional relationship we have. But is it, if we can give people tools that would allow them to better participate in sustaining their own health, I think that's also very attractive.
Super, thank you, Neesh. And Randy?
Two things to talk about is that any discussion about access to data immediately raises this issue of patients' disposition on their own data. And I think there are two things to say here. You see it in some of the chats, is that our context is as a social democratic jurisdiction in which we provide, based on a Saskatchewan politician, Tommy Douglas, free healthcare, and Alberta Health Services is one of the implementations of that. We provide free healthcare, and we're seeking to do health learning systems to improve the quality of that delivery. If you opt out of providing your data and its role in improving systems, then you have to be asked whether you want to be able to participate. That might seem a little harsh, but on the other hand, nobody talks about the risk. So nobody talks about the actual possible, for example, dual use of the health learning system. What would it imagine? So suppose some data gets leaked and you receive 3 messages a week about whether or not you need a walk-in bathtub, because that's how the interpretation of the data has gone. That's meant to be provocative, because I want to see an assessment of the risk, not just blanket pushback on what the risks might be or not. I mean, the spectrum of people who give up their data, most of the people I talk to of the recent generation, sort of sweet spot of the current undergraduates, are prone to ask, oh, I thought all my data is being used for research already. And there's another demographic that says, no way are you using my data. And then we'll say, no way are we providing you with healthcare. So that's also a sort of a caricature. But I think those two things have to enter the conversation, or we will continually run into the, oh, how are we going to keep this secure to keep every last citizen happy? And we'll never do that.
And just watching the chat box in terms of the data quality, right? So just a pitch for a bias in data. And I think, I do think we have, and I've noticed in some of the projects we've supported early on Alberta Innovates with respect to machine learning, when the data is given over, there's many holes in our data, right? So, and that gets back to the point that Neesh mentioned about, you know, physician burnout, and you know, it's difficult, and the book that you mentioned, Randy, at the beginning, Eric Topol's book about deep medicine talks about, there's a line in there that says, wouldn't it be great if the physician spent 13 minutes talking to the patient and 2 minutes pecking for data, as opposed to 13 minutes pecking for data and 2 minutes talking to the patient, and they can get back to the true care. And that's not just for physicians, for all care providers in their interaction, that exchange. But I would make a plea, one of the learnings is around data quality and data literacy, and the importance of that as a jurisdiction. That is a foundational element that we all have room to move on and improve in. I did see in the chat box, there was a conversation about, a point raised about, and it may get back to Neesh's comment about, and maybe I'll put Lawrence on the spot a bit, about the low-hanging fruit and not potentially going at direct care providing predictive capability, but looking, I know you're working on a project now, Lawrence, for COVID-19 related to supply chain, and something, we're just taking data around administrative data and begin to apply that to healthcare. Is that a route of sort of proving the concept and then expanding it out beyond that as a jurisdiction, as opposed to jumping right into the chronic care prediction of a patient, which has all the issues around security? Do you want to comment on your project, Lawrence? And then,
yeah, sure. Thanks, Tim. So it's not my project. It's Dr. Anne Snowden from the University of Windsor, and she is a world expert in thinking about supply chain and health. And what she has observed is that Alberta leads the country in data that has supported their supply chain, and the outcomes in Alberta have been largely or significantly contributed to by the fact that the supply chain was not broken. It's an integrated system. She spoke to scenarios in other jurisdictions where there was hoarding between hospitals and cities and towns, and that really just not something that's been observed. And so it is certainly an area where the application of the data sciences is fascinating in terms of trying to improve things. I'm just amazed. I order too much on Amazon, but I order something on Amazon and it arrives in my door the next day. Like, the coordination required for that is just outstanding. And I know for sure there's a lot of algorithms behind that. There's a lot of prediction behind that. Somebody predicted I was going to buy that before I bought it. That's why it was in a warehouse close to my home. But that is a very interesting application. Things like supply chain, things like supporting the health system. The other application I'm intrigued by is that I learned of this from Michael Brudno at SickKids, and he talks about using the prediction of AI or ML to guide the care pathway, not to make a medical decision, but to guide the care pathway. So you arrive in the emergency room, and an appropriate indication or appropriate action for that patient based on their symptoms is an X-ray, that they're guided towards getting that X-ray so that when they meet with the clinician, the information's there. And it's a low risk proposition. No medical decision has been made. It's still in the hands of a care provider, but their care may have been improved. The flow through the emergency department may have been improved. So those are two interesting ideas that I think are there and ripe for solutions.
Super. So now let's shift. Let's go to it's your turn. Open mics. Let's go. People come. I'm Mark Leduc. You're a brave soul, Mark Leduc. Thank you for coming off mute and asking your question. There's more brave souls out there, I know. There's lots of activity in the chat box. So who wants to come off mute and ask a question of the panel? Now's your chance. And we have about 50 minutes left in this session. So feel free.
Yeah.
Tim, it's Tracy.
Oh, hey, Tracy,
sorry.
Go ahead. Yeah.
Oh, no, somebody else was trying to chat. So is it okay? So Lawrence and Neesh and Randy, thank you. I know you assumed the kind of you kind of talked around, informing your patients about the value and whatnot. I've heard from a lot of patients, they want to be part of the co-design. And so when I think about it, this being a push from industry and a pull from healthcare, I think there's a third vector there, and it's a pull from patients, because we're no longer an acute episodic system. We're more of managing chronic disease over the lifespan. Just wondering what your thoughts are about how we build that third vector in at the beginning versus trying to convince at the end, and your experience, your thoughts there, please.
Let me say something from the computer science data gathering point of view, is that my AHS colleagues heard me more than once ask them what the A stands for. Is that Apple Healthcare or is that Alberta Healthcare? And of course, the reason I ask that is because we need to, as Lawrence alluded to earlier, we need to be able to engage with patients to help coordinate the capture and refine the kind of data captured to be able to best inform our health system. Sometimes the Fitbit data is useful. Sometimes the data is not useful because it's not been calibrated appropriately, or all the other things that can happen with sort of individual generated data. But we need the system culture to say, here's how we can use the data you generate. So we need, if you like, a portal that's very much a portal the same way that there's a emergency room physical sign that says, here's where you go for acute care. So I think that that's one of the things to note, is that we can't afford to ignore the data, but we don't have We have only very brittle systems. I know frontline physicians who are eager to take data, but from a system-wide point of view, it's harder.
I just totally agree, Tracy, and it requires a cultural shift in the research and innovation ecosystem, right? Yeah. If you can't make any assumptions about what the problem is, and you are making assumptions about what the problem is if you're not asking a patient what the problem is. And so, so I think it does require that cultural and shift in the innovation ecosystem. Kudos to SPORE for, I think, really initiating that change in thinking, this strategy for patient-oriented research. And we just need to keep driving that messaging, insisting on it, right? I mean, you know, it's a standard maybe for the adoption of innovations. If, you know, getting a CIHR grant, it's a standard. Why wouldn't it be a standard for the adoption of innovations? So anyway, that would be, it's a big undertaking, but critically important.
And Randy?
Or Neesh?
Or Neesh, sorry, Neesh, sorry.
At the risk of sounding a bit self-serving, I would say that the strategic clinical networks are the ideal vehicle for this, right? So, I mean, this is really a multi-stakeholder partnership. We have patient participation collaboration. We have patient priority setting. So, you know, to not leverage that infrastructure that we already have, I think is a missed opportunity.
I agree. As Neesh and I have had that conversation to say that the SCNs are an experiment that doesn't quite cover the full spectrum of healthcare, but it provides sort of lead points in interacting with a variety of classified diseases and patients. And that's where we can gather data and inform sort of system-wide what works and what doesn't.
Super, thank you, Randy. And again, the SCNs are, for those that are not familiar with the learning health system, they're microcosms of a learning health system in action, right? So, and those are assets that we have. And when I was reading the literature about learning health systems preparing for this this session, I was struck by other provinces. They have, and I've lived in Ontario and BC, but they have multiple regional health authorities, multiple hospital boards, multiple institutions. We don't have that barrier here in Alberta, right? So that's, I think it's a question of that innovation stack and how we put the layers together. But we have great advantage here we need to take advantage of. There was one more person who tried to get in around Tracy. Do you want to come on the off mute and ask your question of the panel?
Yeah, it was David Lawton. I'm DGL on there.
Okay, hi David.
Okay, my question is, and I don't know quite how to frame it, but so I'll just make an attempt, and it's probably not going to be well framed, but I'll try anyway. If you have a somewhat dysfunctional system, and AHS is a dysfunctional system at this point on all sorts of fronts, how cleaned up does the system have to be before you can actually use techniques from AI and machine learning to try to improve it?
I would say in the case of assessing what our strengths and weaknesses, we don't have the luxury of time on this planet to clean things up first and then deploy things that we have confirmed may provide advantage. But it gets back to what Lawrence said. I think that one would want to continually reprioritize where those dysfunctionalities might be and what caused them, and use that to focus the resources that we have, which are never sufficient to be able to see that. So I see, for example, that when I talked about contact tracing, is we can do so much better on contact tracing if we have broader access to data. So I know that as a data scientist, but that might be perceived by you as a dysfunctionality in that we're not doing the very best we can because we simply aren't organized enough to be able to do that. Maybe by the next pandemic we will. So I would rather phrase it as saying, use Lawrence's position to articulate what's not working, prioritize there, and hope that we can adjust and sort of rebuild or address the dysfunctionalities along the way. When you compare what our healthcare system can do compared around the world, maybe the calibration of the dysfunctionality isn't as severe. So I'm not one, and I don't know of any of my AHS colleagues that say, this is perfect, we've got it right, get AI people out of our face. On the other hand, we have to build it as we go.
I'd add the perspective of capacity. So I mean, the pace of innovation in the digital sciences far outweighs the capacity for the health system to absorb it, test it, or even experiment with it. And so there's going to be a challenge in sort of getting the solution or that's being proposed to the front of the line in terms of being introduced. And so again, I don't think you can wait for the perfect system, but it is going to be solved one problem at a time. And I think carefully curated problems with carefully chosen solutions with stakeholder buy-in are the ones that are going to succeed. But it will be, I think it will continue to be somewhat frustrating because the pace of innovation, I mean, we just on COVID-19 studies alone, we can't do them all. We're having to say we can't coordinate. There aren't enough patients. We don't have time. This, you know, there's any number of barriers. So there is a capacity challenge there for sure. But again, back to, you know, the multidisciplinary nature of these things and involvement of stakeholders, those are the ones that get some traction and move forward. And we got to do it one problem at a time. We can't wait for things to be perfect. AHS, as does the university, has its challenges, and it's never going to be perfect. So we have to move ahead with what we've got.
I wasn't suggesting you need to be perfect. The question is do you have to have a base level of functionality where you actually have people who have enough time? Like for instance, 3M would have people set aside 10% of their time as standard employees. You can't do that in AHS when academic physicians are forced to work 70 hours a week just to do the minimum of their job without thinking about innovation, and are dealing with support systems that are totally inadequate. Their time is not valued at all. And so, you know, if that's the system you're working in, how much of that has to be cleaned up before you can actually think about doing some of the stuff that you're talking about? AHS doesn't know. The AHS doesn't know what the value is of an extra potential deceased donor,
right?
An organ donor to its system. It can't calculate what the cost of a transplant is.
Right.
Cost benefit analysis of the transplant. You had people outside of the system, high quality people, spending millions of dollars of volunteer time, trying to tell AHS, get the data to AHS or out of AHS to figure that out, so we can figure out whether we want to have best practices in deceased organ donation. It's totally frustrating.
Yeah. And
if you can't do that, how are you going to do, you know, precision medicine?
Yeah. Yeah, I don't have the answer, but it's a great point.
Neesh, do you want to add or?
No, I don't really. I mean, it is a great point.
Mm-hmm. Okay. Well, I think just looking at the chat box too, I think we have to innovate our way out of these challenges, right? So innovation is the way forward, right? So we have to find our way through it, and that's a collective team sport we've all talked about. So actually, I do have one of the limitations of technology. We're going to upgrade. I guess my computer's going to shut down for an upgrade, actually, and I'm not able to stop the countdown. I have 3 minutes left. I can probably get on my laptop, on my iPad here. I'll probably go to my Apple product. But anyways, any other questions from the audience or from those assembled tonight for this panel?
Hi, I have a question sort of for the clinicians, and maybe Randy could chime in. Elliot, I'm a data scientist at the Center for Health Informatics at UFC, and I'm cross-appointed at AHS. So I know we can create incredible models if we get all the data. We can get very, very accurate models. But clinicians, I don't think will have the appetite for that kind of complexity in these models. And then we have so the best example I've seen in clinical sort of ML, sorry, is the diabetic retinopathy case, where you can diagnose that in images. But in order to actually get that FDA approved, they had to sell the entire imaging system with it. So you have the same type of images in each time. And here, it seems like we have a very similar problem in EHRs, where the differences between EHRs will kind of prevent these algorithms with all the data from being translatable between systems. So you can make a very great algorithm for one system, but it's useless for everything else. And there has been some work with like OMOP trying to standardize these things, but that doesn't seem to be very well adopted at all. No one really has an appetite for that. So how do we combine these things is my question. Like, where is the cutoff between complexity of these models and wanting to put all the data in it versus having a simpler model that a clinician can sort of read through a diagnostic list, sort of like a Charles comorbidity score?
Let me answer that from the computer science, data science point of view. For all of you who think deep learning is the only thing happening and is the only future, pause or read more, because that's not the case. So the question about complexity of models, this one is particularly interesting because it is indeed the case with companies I work with where the finite small data sets used to build models for the particular capture devices do embed the biases of the manufacturer. And so you can't generalize the model to use used in other places because the model is rendered at an inappropriate level of detail. A multi-dimensional probabilistic distribution of the attributes you've chosen, which are different than someone else, is not a way to convey a potential innovation to a clinician in making interventions. It's simply wrong. What we have to do is not give up on accuracy, but continue to move the yardstick in the science to be able to enable the capture of knowledge that builds trust directly. And that's a very hard thing to do. And so I'll defer to my colleagues about simplicity, but if we don't make the capture and deployment of the knowledge done by machines simple enough to build confidence and quick interventions with the clinicians, then we lose, right? The health learning system will never work.
Okay, thank you, Randy. Other comments from the panel?
Thanks for coming back, Tim.
Yeah, thank you. Yeah, quick switch in technology. So
Apple Intelligence, right?
Yeah, I think we're at time, everyone. Great discussion tonight. Really want to thank Christy, Kirk, Sivan from the Alberta Machine Intelligence Institute. Thank Randy and Lawrence and Neesh for their great insights and their commentary, and lots of great comments and insights we can use and build on the winning conditions for Alberta. So really want to thank you for that. And I'll turn it back maybe to Christy to make some comments about the next. This was the second meetup, I think, of a series of meetups that you're planning to do. So Christy, over to you, and thank everyone for attending this evening. So thank you very much.
And a huge thank you to you, Tim, for navigating this conversation and all of the technology involved with it, with the engaging conversation on chat and the people raising their hands. This is an important conversation, and Alberta is a very special place where we have this world-leading institute in artificial intelligence in Amii. We have an incredible provincial healthcare system, and we do have those trademarked SCNs as innovation engines in this province, and we have partners in our academic medical centers who want to move this discussion forward. So on behalf of Amii and the Faculty of Medicine and Dentistry, this conversation will continue, and we hope that you continue to engage in it. So after today, we will be posting this live on this presentation on Amii's YouTube channel. We hope that you'll share that with those who weren't able to attend tonight as we gear up for the next conversation. And we will be sending out a survey, and we will be inviting you to help us inform the programming of this series. So a huge thanks to our panelists for the robust discussion and the forward thinking about what can be. I think we're talking about the art of the possible, because the time is right, the people are right, and the opportunity is right, as I can tell by the faces that I'm seeing on this screen. So I think we wish you all good health, and we look forward to collaboration in the future, and look out for that email that'll be hitting your inbox soon.
Thanks everyone for the engagement. We can't shape this moving forward without engaged people.
Agreed. Thanks, everyone.
Thanks, everyone.
Thanks, everybody. Really appreciate everyone's contribution. Have a nice evening.